And welcome our first moderator of the first panel, Dr. Lakshmi Lavanya Alapati. She is a managing director and senior endocrinologist at American Institute of Diabetes and Endocrinology, Hyderabad. She has done her MBBS from Siddhartha Medical College, Vijayawada, India. She is also a fellow of the American College of Physicians and Endocrinology as well. She has done MD in internal medicine at Cornell University, Lincoln Medical Center, New York, USA. I would also like to welcome our panelist, Dr. Srinath Aswathia, MD General Medicine, MRCP Medicine, MRCP Endocrinology, CCT UK Diabetes and Endocrinology, FRCP London. He is a consultant of endocrinology at Kaveri Hospital, Electronic City, Bangalore. He is also an ex-executive committee member at KES. He is a former consultant endocrinologist at King's College Hospital, London. He is the recipient of the Best Trainer Award for South London trainees. And he's also an organizing chairman of Beacon 2024 and 2025. Next, I would like to call the second panelist, who is Dr. Ashok Venkat Narsu, MD, DM Endocrinology at Sanjeevani Thyroid, Sugar and Hormones Clinic. He is a faculty at regional, state and national conferences, and he has started a health awareness foundation called Sanjeevani Arogya Jugruti. He has been awarded with RSSDI Excellence in Diabetes Care Award 2018, and he has also won the Times Icons of Healthcare Award in 2023. Next, I would like to welcome Dr. Sharat Putta, who is a liver transplant specialist. He is the head of Department of Hepatology and Liver Transplant at Apollo Health City, Jubilee Hills, Hyderabad. He has 28 plus years of experience in liver transplant, hepatology, ERCP, and EUS. He has also expertise in advanced endoscopic procedures and complex liver disease management. Next, I would love to welcome Ms. Sridevi Kakarlapudi, founder and CEO, Remnutri Health. She has done her MSc in Diabetes Care from University of York, PG Diplomas, Nutrition and Diabetes from UK in India, and she's also a registered dietitian in HCPC UK. She has 25 plus years as advanced dietetic practitioner in UK and India. She's expert in scalable, patient-centric metabolic care delivery. Now that ends our moderator and panel, and I hope we can begin our Beyond Obesity panel with this enthusiasm.
Yeah, you can give it to all. Welcome to all of you. Thank you, Dr. Shyam and Dr. Bhavani, Idea Clinics team, and all the sponsors and all the elite group here present on a Sunday morning on the International Yoga Day, that you found something equal and maybe better than yoga to connect with soul, mind, body of metabolics today, discussing on some very fresh topics. Starting with obesity panel, thank you for inviting me. My job is only to coordinate the panel members here who are so elite, and they have a lot of experience, and they want to bring over some very good take-home messages in terms of treating obesity, as it is a chronic, relapsing, I would say non-remitting, or even if it remits, it's a temporary remission. It doesn't give us much hope. It comes back and comes back. And that's why we need to understand the reach beyond, which interpenetrates and transcends the metabolism of the main factors which bring up obesity, and how can we go beyond that. So I'll start with Dr. Srinathji. We have a few questions for you, sir. How would you define obesity? Because obesity has become now a stigma. People don't want to call themselves obese. They don't even want to recognize themselves as being obese. They say, I'm unable to lose weight. and they don't understand the term of BMI, or some of them over understand the term BMI. So they don't understand how to go based on a BMI alone. So I have a few questions for Dr. Srinathji. He's an endocrinologist here, Elite panel member. So we wanted to bring up a few topics for you, sir. I wanted to ask you, for the sake of audience, if we treat obesity based on BMI alone, how would you distinguish BMI as a measure, and what do you call, like a thin fat obese person? Is obesity really a disease? Are we dealing with lifestyle problem alone? Is there a risk of losing muscle mass when you're chasing the rapid weight loss? Why do some lose more weight than others? And what is the age limit for starting of GLP-1 agonist in pediatric adolescent group? Because that's one major effect. We see that we have 40 million obese children now, and obesity prevalence in children is rising big time. With almost 1 billion adults being obese, we have 40 million children with obesity, which is a huge problem in India as well. So I would ask you to bring one small aspect of childhood obesity also into your discussion points. So these 3-4 points I would ask you to highlight today. Thank you.
Thank you, Dr. Lakshmi. Good morning, everyone. At the outset, I'd like to thank Idea Clinic, Sham, and his team. Year on year, I come here. It's a passion that is driving this such a wonderful sort of conference or event where a lot of knowledge we do share and we learn as well and take home. And also Yoga International Day. I think whoever has participated today morning, congratulations. I think since we were traveling, we couldn't. Hopefully we'll do something. So a lot of questions you have put it across. So most important is now it's very hard for us to come out of the term obesity. You actually have asked many questions, and the most important is now in our practice we are starting to use the term ABCD, which means it gives us an opportunity for the patient to understand that we are not coining them as being obesity, at least high BMI. We'll come to that as well. So the patient starts thinking, what is this ABCD? So many people have asked me, what is ABCD? Then I do tell it's something like an adipose tissue, which is a fat tissue disorder. Simple, we leave it at that. Unfortunately, they become large BMI, that's what we call. So nobody likes to be called obese, and every obese patient, if we call them as so, they would never want to be in that position. Why did they happen? Did they happen by chance? Or unfortunately, was it the genetics? Or did they actually inculcate some sort of behavioral problems? Or finally, the hormonal? So now we have actually understand, I will put it as ABCD for the thing. ABCD actually, it is a multifactorial. It is no more a lifestyle. Probably by 2035, it is learned that our population will understand that ABCD is going to be a second sort of a diabetes. Now everyone understands diabetes. They know that it is going to be their baggage for rest of their life. They have to take medicine. Although certain banners are talking about the remission, reversal. Remission is okay, but reversal is, we as metabolic, whatever we are practicing, we don't accept that can be reversed. Remission is fair enough. So the bottom line is, it is for the concerned patient, family members, relatives to understand that it is a serious metabolic disorder, which can be reversed in certain situation and kept in remission for a longer term, provided they practice certain important lifestyle, which we'll be discussing again and again over time, because that is the most important aspect, and for them to understand that it can cause serious problem. Now what are we? We have a hepatologist here, we have endocrinologists ourselves, we also have diabetologists across the forum also. So if you're talking about ABCD, then you see a lot of liver disorders. Still, people have not understood what is a liver disorder. Many doctors even don't have a pathway to learn what should they do. Should they go into liver enzyme? Should they do some scans? Do they do advanced? When to refer? These are the things. Last night also I was in a forum, then the referral pathway is actually not robust. So we have a lot of things to do. And we know that it is no more lifestyle. So it is a multifactorial. It could be from the adiposity itself, it could be from the neurotransmitter from the brain itself, or it could be from the genetic, it could be from the hormonal. So lot of things. We have learned about the gut hormones. We are now learning about the brain as well, how the mice or the experimental models behave compared to the human, because there are some GLP-1 receptors noted in the animal models which are not there in us. So lot of things. And we have lot of things to do, and our patients now have got lot of opportunities. So we as clinicians, we are learning about the new molecules. We have learnt it, and over 2 decades we have now used those molecules, coming from the GLP-1 starting now into the once week. Maybe in future we will see once monthly also. So people, doctors are actually now getting more trained. They can use these molecules, they can discuss, it's more affordable. So which means patients have got the opportunity to improve on their metabolic status, I would say. Having said that, how many of them accept it as an ABCD? How many of them understand what it can do is a big question. Hypertension, yes, we have agreed, it's a chronic disorder, they take the medicines, they miss it, they know what's the problem. Diabetes also, they have got complicated. But nobody is aware of what is happening with the ABCD. And finally, you touched upon the children. Children, actually I'm not a pediatric endocrinologist, but we have learned from our pediatric colleagues. CMC Vellore has done a wonderful work on pediatric GLP-1 modules as well. They start GLP-1 injections at 11, 12 years or so. Not licensed, but they have done a lot of studies to support them. A few endocrinologists who have done pediatric, they are using. Childhood obesity is the most important. We have a responsibility in our hands. If we see a patient of yours, whether it comes for diabetes, hypertension, or any other this thing, if you see a child accompanying or a family member accompanying, and if you see them little high, with a high BMI, it is for us to identify and actually pass the message on that it is going to be a serious concern and you need to understand. And then probably the ball will start moving. We have to tell our patients. How many of us have in our clinic have not seen a patient coming with a BMI of 28, 29, 30, diabetic patients? What do? We are busy probably looking at their targets, complications. We are good at that. But are we good at telling them that you are a little bigger than normal, that can cause serious complications, because the patient has not coming about that term. So what the patient says is important for us, but when they walk out at probably one message that you are big, we can always discuss this later on, and so on. So I think I've opened this for many things. I think the panelists are there, and I'm sure lifestyle disorder is not the only one. If you eat less and if you do more activity, the high BMI is going to reverse. Probably that's still a myth.
Thank you, Dr. Srinath. I think that was a good set point for us to start our discussion. I'll go with more precise questions from now on, a little rapid fire in the middle. The body of the discussion, I want to do a little rapid fire. That'll wake us all up. So, Dr. Ashok, would you just take BMI into consideration?
Yes,
if so, then what about the visceral adiposity versus a general subcutaneous adiposity? I mean, the overall adiposity. Yeah. And how can you have a BMI of 23 with the visceral adiposity demarcated from the other? And would you use the waist-hip ratio in that regard? What is the importance of BMI, waist-hip ratio? And how would you place DEXA scan or any other body fat measurement aspects? Because it has become a fallacy. It has become a fancy gadget now these days. Patients come with, my body fat is this much. So we want you to highlight on these 3 particular points. A rapid fire. We'll keep it very short to the point. Thank you.
Thank you, madam. So first of all, I want to convey my sincere and heartfelt thanks to Shyam sir for giving this wonderful opportunity. As you mentioned rightly, madam, one of the fundamental tool at least we need to see is BMI. There is no doubt in that. Sometimes even we might miss in our busy schedule, but it should not be the excuse. BMI has to be there. Along with the BMI, we need to inculcate from today onwards, like waist circumference and waist to height ratio. So waist circumference, why? Because we are the Indians, like Asian part, we are more prone to develop the cardiovascular complications and diabetes per se at a lesser BMI at a younger age. We are the people more prone to have the central adiposity compared with the generalized obesity. the central adiposity is the driving factor for the insulin resistance and related complication. As sir was mentioning, like it is not only restricted to the diabetes and dyslipidemia, but also the one of the well-known underdiagnosed, unnoticed complication is a metabolic associated dysfunction associated steatohepatitis or liver disease, MASLD, the new term. So such kind of things are happening at a lesser BMIs in our part. The well-known phenomenon called YY paradox. At a given similar BMI degree, when compared with the Western counterpart, our counterpart is having higher body fat compared with the Western part. That is Yajnik and Yudkin pictorial representation, landmark pictorial representation, which is published in the Lancet. Another one is like, to in a clinical scenario, rather than going for sophisticated investigation, what kind of parameters which will tell us that this person is more prone to have this kind of complications, like waist circumference, simple tool, the midway between iliac crest and lower part of the rib cage. Then in a woman greater than 80 for Asians and men greater than 90, then waist to height ratio more than 0.5. If these things are there and already diabetic individual or hypertensive or dyslipidemic individual, at least one time LFT and CBP to calculate the FIB4 score and make the individuals categorize as a where he is falling from that particular point of view. Is a low fibrosis risk individual or moderate or high risk individual. So these are the things. And coming to the DEXA scan, yeah, to give the precise answer, yeah, BMI, it might give overestimated value if the person is doing regular gym and bulky person. It might give the underestimated value if the person is lean but centrally obese. It will give the underestimated value. But DEXA will give the precise answer in terms what is the body fat percentage and fat distribution also. And what is the central fat distribution and what is the muscle mass. And sometimes the person around 55, 60 years, what exactly the simultaneous picture of the bone strength as well. So the kind of overall picture will be given by DEXA if we use properly. But the thing is the availability and these things
Yes.
are really matters.
Yes, of course. For a poor man, I would ask them to stand in front of the mirror a full length, just look at your profile, look at your arms, legs, the muscle in your arms and legs, the extremities and the belly, the pot belly. Do you have a pot belly? And can you see the tip of the toes from where you're in the vertical position?
True.
And just have a side pose and look at the bulge. How many months pregnant are you? By not being still, not yet being pregnant, but pregnant with the fat in the viscera. Yes. So these are simple measures for them to shame. I mean, when I talk, it gives them a little sense of guilt, a sense of shame, and it may hurt them a bit, but again, do it with a smile. And do it simply, because this is what they need to understand. This is our life. You have to openly face it. Face in front of your mirror, strip yourself and look at the mirror. Look at you completely. Take a pause. Just think, where did you come? What is the journey? How can you go back? It's basically a self-questionnaire. Compared to all the costly gadgets, the metabolic gadgets that we have, we are talking about this world. I'll move on to our gastroenterologist in the panel, Dr. Ashok sir, and he has very good points that he has for us, but I'm going to, let me 1 second. Dr. Sharad sir, Dr. Sharad Putta is a gastroenterologist, and we wanted him to highlight today on is all the fatty liver the same? Because we use the term fatty liver in a very loose format. Every ultrasound that we do for any reason, any master checkup, executive checkup will give us a grade 2 fatty liver. It's like, select B if you don't know the answer for the NEET exam question. B or C will most likely be right. So you just select B. So here our guess point is grade 2 fatty liver for no matter what the condition is. So how would you look at the grade 2 fatty liver of ultrasounds of all our patients? And what is the natural history of the fatty liver disease? How does it progress? It's a continuum. Like the HbA1c. It's a continuum. It's not like it has a starting point and ending point. It's a journey again. Fatty liver is a journey, I think, natural history. So what are the proven lifestyle interventions for fatty liver disease? What are the take-home messages for the audience here? How seriously should we take care of this loose term fatty liver, and how would you metabolize it into MASLD, NAFLD and all that stuff, sir? Thank you.
I think I don't know how many of you know, but there are jobs in the West which are designed to just cater to patients with fatty liver disease. So where I worked in the hepatology department, there was a guy called Phil Newsom. His job 5 days a week was just to treat fatty liver disease. So 2 decades ago when I was working there, we saw this guy and said, okay, this guy must be mad. It was the most boring part of hepatology when I did hepatology. The more exciting parts were interventional endoscopy, ERCP, US, transplantation, viruses. So we were all looking at that. Now, so for me to summarize this whole thing in 3 minutes, 2 minutes is going to be difficult, but I'll just make some generic statements. I think now we have a hammer in our hands, which is advanced diagnostics, and everything looks like a nail. So we find fatty liver disease and we all freak out, okay, fatty liver disease. So there is one thing that comes out of European data. Scandinavian countries are very, very good at doing population studies. It's just an observational longitudinal studies. If you have fatty liver disease, let's say there in the population there's 1 million people who have fatty liver disease, there's 1 million who don't have fatty liver disease. You compare the two groups, they are no different. It's not like the fatty liver group is going to have more liver related events or more cancers, more cirrhosis, or they're going to die early. The evidence is not there. You have to look deeper. Not all fatty liver is the same. So the question is it all the same? No, it is not all the same. If you have fatty liver disease and you have the metabolic syndrome, so if you have diabetes or obesity going with it, that is the risk group. Again, you substratify this risk group. Not all fatty liver disease obese patients are going to have adverse outcomes in their life. You substratify this group. So patients with fatty liver disease, if they have abnormal liver function tests, so obviously when you do a scan, you find a fatty liver disease, you're not going to stop there, you'll do liver function tests for these patients. So if the liver function tests are disturbed, then you know that this patient has fatty liver and inflammation. So that is one thing you take into consideration. Now once you have fatty liver and inflammation, the next thing you want to know is, do these patients have fibrosis? The single most important thing in liver disease is if the patient doesn't have fibrosis or scar tissue in the liver, they are generally okay, the liver disease is reversible. They don't have any risk of having or progressing to cirrhosis or progressing to cancer. The risk is not there. It is fibrosis, scarring, particularly stages 3 and above. So fibrosis goes from F0, which is normal, to F4, which is cirrhosis. F1 is a little iffy, so we take F1 as F0. So F3 and more is where you start worrying about patients. So fatty liver disease, if they have fibroinflammation. So how do you diagnose fibrosis? Fibroscans are now available everywhere. So it's a very simple test. You just place it in the right intercostal area, and then it takes 5 minutes. So you place a probe, and the probe actually percusses. It's like knocking on a door. So it sends a percussion wave into the liver, and looking at how that wave is bouncing back. If the liver is really, as the liver gets fibrosed, it gets stiffer. It gets more and more stiffer. A cirrhotic liver will be very stiff. So normal liver, if you imagine, is like a block of cheese. It's nice and soft. Cirrhotic liver goes stiff. It's more like holding an apple, for example, not cheese. So those are the parameters or metrics you're trying to assess when you do a fibroscan. So broadly speaking, if you just have fatty liver disease, you're not going to have increased risk of liver-related events. If you have inflammation, you have slightly higher risk. If you have fibrosis, that is when, particularly F3, which is like pre-cirrhotic stage, that is when your risk increases. And if you have cirrhosis, of course, your risk really goes quite high of developing cancer and progressive liver disease. So then there's lifestyle interventions and medication. We can talk about it now or later if you want.
You can finish off.
Questions from the audience in between? Or?
If you have questions, yes, please break us and take a question anytime.
Yeah, quick question to Dr. Sharan. Yeah, because you made a statement that, about the Scandinavian population studies, you said that, fatty liver there for a long time, not much change, and that was our earlier understanding. So I just wanted to ask you one quick question, is there any population data from our country, how fast is the progression? Because when you give a comparison, I mean, you look at pre-diabetes in our country, we say that, there are, across the world, there are many pre-diabetics who progress very slowly. And for years they're pre-diabetic only, and only 1/3 of them progress to diabetes, we say. But in our country, what we see is that progression is very fast. Within a year, they progress to diabetes. So, is any data on fatty liver? How often? I mean, how commonly? I mean, how fast they progress in our country? Is it different from the Western data, or is it the same?
Yeah, I think that's probably the most important question. So, if you have fatty liver, will it progress? So I think we've only just established in the last 5 years, we are beginning to establish our demographics. So there is a multi-center trial led by ILBS in Delhi, which has just established the prevalence of fatty liver disease in our population, which is around close to 30 to 35% in the general population. And if you are a diabetic, it goes anywhere between 50 to 65%. So now how fast does it progress? We have very few prospective studies. All the studies are actually looking back. So you take a cohort of patients who have developed cirrhosis, who have the metabolic syndrome, and then you look back. So the studies from our country looked at, again, most of the studies come from North India, and there's one study from Kerala where they are still prospectively following up patients with NAFLD. So if you have diabetes and fatty liver disease, that is the group where there is rapid progression to cirrhosis. So it is estimated that if you have diabetic MASLD, there's a 5% per year progression to advanced fibrosis. So if you take 100 diabetics with MASLD this year, by the end of the year 5% will have advanced fibrosis, and by the end of 5 years close to 10 to 15% of them would have developed cirrhosis of liver. So that is rapid progression compared to the rest of the world.
Thank you.
Thank you, Dr. Sahai, for your...
Basically, do an ultrasound, you're going to find fatty liver. I think I agree with that statement, sir. I think you'll have to understand the radiologist's mindset also, where if they are in doubt, they report it as fatty liver. There's a bit of over-reporting also when you actually speak to radiologists. And the newer ultrasound machines, I do endoscopic ultrasound, there's so much, the definition is so high, and I think you really need to calibrate, you need to compare the calibration of newer machines to older machines. Definitely there's overdiagnosis of fatty liver. I think fatty liver grade 1 with normal LFTs, with no metabolic syndrome, I actually don't follow up these patients. I ask them to just go back and, maybe, if there's an issue, to recheck their investigations. There's no point just continuously following these patients.
So Dr. Sharath, what is the next step for the fatty liver that we commonly see on the ultrasound? What is the next step?
So
is it the same as we study in the algorithm, the FIB scoring, and then the fibroscan if the FIB score is more? Is that the next step for all of us?
Yeah,
to take
okay.
home?
So I think the FIB4 score is for general practitioner, non-hepatology practitioners. Okay, so it can be general practitioners, endocrinologists, clinicians. So you have a patient walking into your clinic with a report of a fatty liver. So what do you do with that patient? So you do liver function tests, and so FIB4 takes into account your age, AST, ALT, and platelet count. So you do your FIB4 score on that patient. If the FIB4 is more than a certain threshold, which is 1.3 for the Western world, and it is 1 for Indians. So if the FIB4 is high, you can then either monitor them in your own clinic, or you can refer them for further tests for advanced fibrosis. But just broadly speaking, I think if you have a patient with fatty liver and normal LFTs, and if they are not diabetic, I don't think these patients will come to harm from their liver disease. There is no guideline that is asking you to continuously monitor these patients right now. Normal LFTs, non-diabetic, I think you can just there's no need to pursue that liver disease.
I think we have a little difference of opinion here. See, fibros, if you're talking about FIB4 score, okay, you have somebody with high BMI, whether they are pre-diabetic or normal, when you are doing a metabolic workup, we are able to pick up early cues. There could be a low HDL, there could be a high triglycerides there. That is another population we are seeing. We are very risky population because they march on very quickly. And here, FIB score. So what happens to population are coming from northeast? I don't know what is Telangana's population with northeast. There they have a low platelet counts. So FIB score can be a default there. And somebody who has recent illness, like it could be any dengue disorder or any of these, or any hematological disorders, that is where we need to be a little bit careful about the FIB score. So if somebody has got high BMI, irrespective whether they're diabetic or not, we may have to definitely screen for metabolic. I'm not talking about the liver per se here. We are talking about other organs also are there here. So what are the other organs we are worried about? So there could be simple arthritis, could be very, what are the people who are coming with a high BMI suffering from? They are suffering from serious psychological disorders. You said to them, stand in front of mirror, look at them. In social countries, in the abroad countries where they do a lot of social parties, I'm sure we are catching up as well. But there, if you have got a high BMI, they are looked down very, different. So psychological esteem in our patients also are a very important factor. And also the physical ability. We talk about lifestyle disorder, you need to do 150 minutes and 30 minutes of strengthening exercise. Everybody wouldn't be able to do that. We need to look into individual person.
The holistic approach.
Yeah.
I think
Just a very quick point. I think there is a fine line between freaking patients out. I think we are very good at that as an Indian society.
I agree.
Yeah, just go out, everybody is doing awareness campaigns, and not all fatty liver, we don't have guidelines telling us, we don't have good longitudinal studies telling us what to do with patients who have liver disease, who are not diabetic, and who have normal liver function tests. So I think this particular group, until we have good guidelines telling us, okay, monitor this obese patients with normal LFT, grade 2 fatty liver, I don't think we can advocate monitoring all these patients continuously, because there's something called harm that you do by continuously putting them under surveillance. So there is this surveillance harm that, for example, gastric cancer, liver cancer. So there are screening guidelines for these patients. Actually, calling them back for screening very regularly does a lot of psychological harm. There are studies looking at that. So you can say, for example, incidence of gastric cancer is increasing. Should we do an endoscopy on all patients above 50? Then you do the endoscopy, and Barrett's esophagus, for example, and you tell them, I'll repeat your endoscopy after 2-3 years. So that guy is probably living in fear for the next 2 to 3 years. What's my next endoscopy going to show? I think considering that 40% of the population have fatty liver, if we start telling everybody, look out, get your LFTs or get a scan, do this, do that, we're going to do a lot of harm to these patients. Out of the 40%, probably it's only less than 5% that are going to need regular monitoring. Vast majority, I think you can just leave them alone.
Thank you. As you can see, there's a lot of difference of opinion amongst the experts also, the guidelines also, the approaches, the judgment values, and the patient who's sitting in front of you. So it's a very personal decision between the treating physician and the patient who's getting treated by you, with all the knowledge going on, and final judgment has to percolate in such a way that is applicable to the patient. So the treatments are not treatment favored, the treatments are the patient favored. So the institution should not boast, I'm the number one institution. The institution should give rise to a pupil who understands and who got educated well enough to be able to take care of his life wisely for a lifetime. So the purpose of education is not the institution, the purpose of education is the student who got benefited. So similarly, the approach may be different, but the outcomes should be good, and that's the whole point of the discussions. From that, I'll move on slightly, change to Sridevi Garu. She's our esteemed dietitian with more than 25 years experience in the UK and now in India. So her perspectives are much more broader, and I would ask her, do you believe, Sridevi Garu, that food is an addiction? And it has more definite addictive tendencies and capacities more than other substance abuses. I feel food addiction knocking off is much more harder than smoking, alcohol, and other drugs. That's what I feel. Because I'm working on my own food addiction and I'm still not successful. I have a sweet tooth and I'm not successful. I'm mindful about it, I'm watchful about it, I do cognitive behavioral therapy for my own self, but still my craving for sweet is unbelievable, unbelievable. So in spite of being an endocrinologist and a very knowledgeable person on this fact, the fact is fact, but my problem is my problem. What do I do to bridge the two? And what do you suggest your patients to bridge the two?
So what we need to remember is that we are we are in a world right now where the industry is focused completely on addicting us to all the foods that they produce. Their only aim is that you are so addicted that you keep coming back to the same food again. So to fight that, the exposure we have to so much food is also such a big thing. It is not an easy task, not easy for anyone. Not a dietitian, not an endocrinologist, whoever it is. It's not an easy task. So so the fact that we are calling this ABCD rather than obese, because obesity has got this stigma against it, like as though people do it just because they don't care or they're just so careless. So it is something that it needs a lot of discipline to be able to maintain your weight, maintain your health. So it is about how we train our mind right from childhood. And you've mentioned the figures for obesity in childhood. So I think it is in India, what I'm seeing is one of the biggest issues is there is no generational knowledge of foods that are now coming into the market and that our kids are eating and our families are eating. So that is one of the biggest problems we are having. So I think it is more about not shaming, but increasing awareness, having families getting used to having lots of filler foods that don't have calories. So once someone is full, they're less likely to go for foods that are high in calories and high in sugar and high.
So can you name a few filler foods or a few de-addictive foods which can go prior to the highly palatable, highly processed HPF foods, which are of course addictive and very craving for us? Give us a list of those foods that you usually have great success with your patients.
So what we always say is on the table, have always start serving with more vegetables first. Have more vegetables so that they're more filling. Have the food that you like at the end. So then you can have a small portion and feel satisfied. So have the fillers first. I know there's a big thought process in India due to the Ayurvedic belief that you should not drink before eating. But scientifically thinking, we know that it doesn't really apply. But it does help in the sense that if you drink while you're eating, it fills you up. The stretch receptors are better, activated. So you're more likely to feel full and feel stop
drink
eating.
Prior to eating, just prior to eating or while eating also?
Prior to eating and drink while eating. But we know that the body knows how to produce the enzymes it requires. So also eating slowly, I think that cannot be underrated in any way.
Yes.
By eating slowly, because we need to remember that the body takes 10 minutes to even recognize that we have started eating, because that's when the physiology starts changing. Mm-hmm. So most of us finish eating in 10 minutes and then we are looking for what do we have, what else can we eat. Mm. So we end up eating a lot more than we need just because we are not concentrating on what we are eating. Don't watch TV, sit at the table, have a chat, eat and enjoy.
Yes.
We talk a lot about Mediterranean diets, but what we don't understand fully is that, for example, Italians, Spanish, they have a very traditional family sit-down dinners. They eat over an hour and a half or 2 hours.
So those are the countries who have happiness index less than 20,
yeah.
and they go home at 4 p.m. and it's not the case with Indians here.
And
So-
also, yeah, I know. and they give so much importance, and they eat it in stages, like, so they are eating slowly. That is also the crux of it.
And did you see, Dr. Sridev Garu, that we discussed about more than 30 minutes and not one single word of GLP-1 agonist came up amongst all 4 of us or 5 of us. Amazing, isn't it? So we are definitely beyond the GLP-1 agonist. We are agonism here. But what is the role of GLP-1 agonism in, because we can't finish the obesity panel discussion without GLP-1. So whom would you look for a GLP-1 agonist in your patient when you're dealing with obesity? Would you go back and tell the endocrinologist, yes, this is the person who definitely needs a prescription, sir. Please go ahead and work on that while I'm working on the other aspects of the diet.
But, Lakshmi Garu, like you said,
because we're out of time now, so we'll wrap up.
Having control is one of the biggest issues.
Yes, absolutely.
And GLP-1 definitely gives someone who, especially who has, the issue with control, psychological issues with food, it supports them. So using it as a crutch, as a support, is absolutely helpful.
Yes, I like the fact she used the word support. Yeah. She did not use the word as a starting off. I mean, rely on it completely. Dr. Ashok has been waiting.
Just final quick ending point.
Yeah, we're wrapping it up. This is the last chance.
Just to give the proper fillers prior to the main meal, usually we recommend to start with the protein. Because
Tryptophans,
many of our patients are protein deficient. Good amount of protein, then salad, then fruit, low calorie fruit. Then go for the main course. By the moment of you have consumed these 3 things, then at least 30-40% of your stomach is filled, and then the main course will be lesser. So, and taking the main course, generally we used to advocate rather than going with rasam, sambar, pickle, then dal, properly boiled vegetable curry.
Foods. The rasam, sambar, pickle, papad, sambar, rasam, all of those are highly palatable foods. The salty, oily, spicy, the zingy they say, which give you that stimulating effect on the tongue, which is, the basically ventral tegmental area, the nucleus accumbens, and then the dopamine receptor pathway, the addictive neurobiology of obesity is what we need to really deeply understand.
In the simple terms, the equal amount of cooked carbohydrate, complex carbohydrate, equal amount should be the curry. Then that makes us, even layman, to understand fully. They will materialize in a reality to have the good glycemic values.
And also, Dr. Ashok, I see that the people are more on the protein aspect now. They are consuming a lot of animal protein, switching to Atkins diet or some other keto diet. So the keto diet fads are really on the high rise. And as endocrinologist, what is your take-home message on the high protein diet or the protein main diet, or even now with the GLP-1 agonist to save the muscle? There's a slogan called Save the Muscle.
Correct.
And it is against the whole philosophy of GLP-1 agonists. We are using GLP-1 agonists especially for diabetes. Number 1, marketing indication. Second, BMI more than 25 with comorbid illnesses. Third, BMI more than 30, no matter what, whether they're diabetic or not. So don't take the save your muscle philosophy behind, shunning off the GLP-1 agonists. There's a fair market value for GLP-1 agonists. So what do you say on the high protein save the muscle?
To have the healthy life, at least for an adult diabetic individual, at least 0.9 to 1.5 grams of protein per kg is required.
Yes.
By default, an adult individual, roughly 60 grams of protein is required. It is not going crazy more than 1.5 in each and every one. Unless he is doing vigorous activity, that is different story altogether. At least 50 to 60 grams of protein requirement we need to look into.
Yes. And Dr. Sharad Garu, what is the role of GLP-1 agonists in the fatty liver? Because I see Monjaro or any other GLP-1 area as the top line on US FDA approved practical usable treatment for fatty liver these days, sir.
Okay, until 3-4 months ago, GLP-1 RAs were not recommended for use in metabolic fatty liver disease. You only use it if the patient is concomitantly diabetic, for control you use, or concomitantly obese. That is the primary driver, not liver disease. There's a American Liver Society practice update that came in April. So now we are using it for a selected subgroup of patients with metabolic steatotic liver disease with advanced fibrosis. So you need that advanced fibrosis before you treat the patient. Yeah.
Thank you so much. Yeah, she is requesting for one last statement. Yeah.
Yeah, so I think the term adequate protein needs to come in.
Yeah.
Where this high protein always encourages people to think they need 2 grams per kilogram body weight, which we know it's absolutely not.